Hi everyone. So this skill is going to look at taking blood work and a cap change on an IVAD, or an implanted vascular access device, or a portacath. We'll talk about in class about accessing portacaths, but we're going to pretend that our portacath has already been accessed. It's already taped in place. It's been confirmed. So we're going to have the line hanging out here. So that's what we're going to be working with, similar to how your other central lines just have the lumens hanging out. Okay. So for this one, of course, with our blood work, we're going to make sure we have our requisition and it's filled out appropriately. We're also going to make sure that our name matches the patient's name band and another identifier, and as well that our label that's going to be affixed onto a blood tube also matches the requisition and the patient's name band. Okay? So we're going to make sure we do those checks. As well, for our checks, we're also going to need our heparin. Now, we use 200 units of heparin for our non-valved subclavian line. The IVAD is a little bit different in that it needs a little bit more heparin. You can see that it looks to be a longer line, so it requires, but of course check your policy, 500 units of heparin. That's the policy we're going to be following. So 500 units. At 100 units per ml, we're going to need 5 mLs. So when we take this out from the Pyxis or from our med room, we're going to do our first check. Okay? And then when we go to our patient, that'll be our third check. And then when we're double checking our medications before we go see the patient, we're going to do a double check against the MAR to make sure that this is the right heparin that we need. Okay, and then of course I'll need my normal saline syringes, and we need our non-sterile gloves, alcohol swabs, and if we're doing blood work, we'll need our blood tubes and a vacutainer. Okay. Also, a couple of empty syringes as well, 10 cc syringes. So again, I'm going to make sure that I do my hand hygiene. I have nice clean hands and non-sterile gloves. So of course I've introduced myself to my patient and I've explained the procedure. Verified that my requisitions are filled out appropriately. So now the IVAD has no valve at the end, so that's why we need to heparinize it, because remember, blood can back up into those non-valved lines and clot them off. So because we presume that the previous nurse has locked this off with heparin, we don't want to go and flush it. Some policies may say that that is okay. In the lab, as I've mentioned before, we're going to make sure that we aspirate our heparin back. But of course, check your policy where you're working. So first, I'm going to swab my catheter. Interlink cap, 30 seconds, and dry for 15. We'll do the blood work first. And we're going to take an empty 10 cc syringe. We're going to attach that on, and we have a clamp here. So we're going to unclamp that, and we're going to aspirate back about minimum 6 cc's. So what we're drawing back right now is a mixture of heparin that was instilled and patient blood. So we're going to discard that, and we're going to clamp this in between, if you remember, good practice, and we're going to take that off. We're going to send that just to the med waste, okay, or any kind of waste bin that you have. Okay, we don't want to send that off to the lab because it'll show that it's contaminated. Okay, so now we can either use two devices. We can either attach our vacutainer with the blue interlink, and we can attach that, and we can take our blood tube container, and we're going to unclamp, and it should automatically fill to how much you need. It will stop drawing when it's got enough of the blood. Because this patient has no blood pressure, we don't have a lot of pressure exerting on this blood tube. So sometimes it doesn't fill to the right amount. If that happens to you in the lab for demo testing, you can just simply say, I would fill this blood collection tube until it stops filling. Okay? Sometimes there's also lines on here as well, so you know when it's filled to the appropriate level. Okay? Now, if we didn't want to use a vacutainer, if we wanted to use the syringe method, we can definitely do that as well. Okay, so I've sent away my discard. I'm coming to my catheter with my 10 cc syringe. I can also use a smaller syringe as well. It depends how many tubes you're going to be taking. If I'm only taking one tube, 5 cc should be enough. If I'm taking multiple tubes, I might need to draw a little bit more blood work, so that's why I might need a 10 cc syringe. Okay. I'm going to say I'm going to take about 7 mLs. Maybe I'm sending 2 blood tubes. Okay, I'm going to put that aside because I'm going to try to remember to use a transfer device and show you how to use that. Now, I don't want to leave blood sitting in my tube, so I want to make sure, or my catheter, I want to make sure that I'm going to flush this through. Blood is really sticky, so we're going to make sure we flush it really well. Okay, unclamp, and we're using that push pause. Okay, so 1 ml, push pause 1 ml, trying to create that turbulent flow inside the lumen to try to clean it out. Okay, and then if I remember, clamp in between, just a good safety feature, just in case your cap wasn't on there well. Okay, make sure we have all our bubbles out of our syringes. Okay. So another 10 cc's, so that'll be 20 cc's in total of normal saline, push pause, nice turbulent blood flow. Okay, and clamp again. And we're going to remove our syringe. Now, as I mentioned before, heparin, we need 500 units. We would check our policy and our orders. In our policy, it says we're going to use 500 units. That's 5 mLs. So here's my check again. We might have to just kind of get rid of what we don't need. Sometimes it's overfilled. And I'm going to attach that onto there and just instill as normal. No need to push pause here. However, at the end, we're going to add some positive pressure. So at the last 0.5, we're going to push down with our thumb and we're going to clamp at the same time. Okay, clamp and push. Okay, trying to ensure that we've locked inside that line some positive pressure so that that blood doesn't want to flow back into our catheter and clot. All right, so that's heparinizing the IVAD. Now, if we were going to do a cap change, oh, one thing I forgot with our blood work. So remember, I had withdrew this using the syringe method. So now I would need a transfer device to put this into a tube. You could, if you can't find a transfer device, it's not best practice, but you can use a blunt fill to transfer this into a tube. However, you increase the risk that you might poke yourself. So that's why these transfer devices are really handy if you can find them. So it's going to screw onto the end of our syringe and we're going to find our tube that we're sending and we're going to pop that on there. And as before, normally it should fill because it'll just have the right amount of pressure to pull, okay, to the right amount. These tubes have been used a few times, some of them are expired, so sometimes that pressure has been lost. So in lab, just verbalize what you would do or what you would see in clinical. Okay. And we would make sure that's labeled appropriately with our requisition and send that off to the lab. Discard what we don't need into the sharps container, and then we'll move on to our cap change. So for our cap change, we need our interlink cap. We're going to open that up, banana peel it. Don't touch the end. We want that to stay nice and sterile. And we're going to attach our normal saline. Let's get the bubbles out there. There we go. Screw that on and prime all the way to the end there. Okay. We can tuck that back in, make sure that the end is sterile, so we can take that to our bedside. Okay, so to change our cap, we've got all of our supplies. So we're going to swab our port here because remember, the last nurse should have instilled heparin in there to make sure that our line doesn't clot off. So we're going to have to take that heparin out. So we've swabbed for 30 seconds and we let it dry for 15. We've attached an empty syringe, unclamped the line, and we're going to pull back. And what we're pulling back again is a mixture of heparin and patient blood. So we just want to make sure we get rid of that heparin so we don't flush it into the patient. Again, check your policy. Okay, so we were going to discard that heparin, and now we're going to do our cap change. So we're going to take our alcohol swab, and we want to make sure that we clean where the cap attaches to the lumen, just because there might be some blood or stuff or debris caught underneath there. We don't want to disrupt that and make it go onto our catheter. So let's clean up that connection there. And then making sure that this is clamped, we can take off our cap. So make sure your clamp is enabled because we don't want blood flowing back and we don't want air going in. So remember, we have our cap and it's primed and ready to go. Now, if we notice that there was anything crusted around here, we can definitely clean around this lumen. As I've mentioned with the other lines, the jury is kind of out, or the literature doesn't really say yay or nay whether we should clean there. However, it does make sense if it looks dirty, if there's blood crusted, if there's medications crusted on there. We don't want to put a nice clean cap onto a dirty line. So it makes sense to clean that up a little bit. So once we've cleaned our lumen, we're going to take our cap, take off that blue cap, and we can see that it's nicely primed. There's no air bubbles, and we're going to attach that right onto our line. Okay, we're going to unclamp, and often you'll see nurses will pull back a little bit just to see that little flash of blood. Tells us that we're still inside the vein, or in this case, we're still inside that port. Okay. And so we're going to flush with 10 cc's. We're going to use the push pause so we can clean out the lumen. Now, we didn't really draw any blood except for that heparin blood. It was heparin mixed with blood. If we were doing a blood draw, we would flush with 20 cc's because we had just patient blood, which is really sticky, sitting inside the lumen. But we didn't do that. We just changed the cap. So what we're going to do is just flush with 10 cc's. Of course, check your policy. If, however, the line seems sluggish when you just flushed it with 10, you can definitely flush it with another 10 if you wanted, just so that it's, you know that it's open and flowing well. Okay. However, it flushed beautifully for me, so 10 cc's of normal saline was sufficient. Now, remember, because this is a non-valve line, we need to heparinize it. Because it's an IVAD, we checked our policy. Our policy says to heparinize with 500 units of heparin, and that is 5 mLs. So I did my med check when I pulled it out of the Pyxis or the med room. I also did a second check comparing it to my MAR before I came into the room. And then my third check at the patient bedside. So it's kind of not the same as our med checks as previously, but still we want to make sure we're giving the right heparin. Okay, make sure we get all the bubbles out. I didn't put down my catheter at all, so I'm okay just to hook that heparin right onto that cap, unclamp it, and we're going to just deliver a nice steady stream of heparin. No need to push pause right now. However, at the end of our heparin, the last 0.5, we're going to give that positive pressure. So again, we're going to push with our thumb and clamp at the same time. There we go. Hopefully that positive pressure will help to make sure that blood doesn't flow back into our tubing and prevent any clots. So of course, after I've given heparin, I would make sure I chart as well. And on my flow sheets, I would make sure that I chart what I have done to the line.